Thanks for inviting me to speak today. This is actually one of my favorite topics to talk about, in addition to when it's not a hemorrhoid. This is actually something I try to talk to my residents about all the time, but you can definitely see their eyes glazing over, so I'm glad that you guys are willing to spend 10 minutes listening to me talking about stoma creations. I have nothing to disclose. So really the big questions here, when should you relocate a stoma? I think other faculty members have said, when you are unable to reverse it, I think that's the number one thing that we think about is you should really try to reverse the stoma if at all possible. That's probably the thing I think about most when I think about parastomal hernias and anybody who has an ileostomy or a colostomy. Can I reverse this? The other opportunity to try to think about relocation is if it's actually in a poor location, and then if the patient has poor skin integrity from having that parastomal hernia. So if you're thinking about repairing the parastomal hernia, and the skin is just not adequate to try to keep well-functioning stoma, then you should think about relocating. There's important considerations to think about when resiting or relocating a stoma. Is this absolutely necessary? Again, I cannot stress enough, if you can reverse the stoma, just reverse it. Because the recurrence rate for putting in a new site is actually pretty high, anywhere from 32 to 89%. At the prior site, it's 8% to 52%. So again, do we really need to be resiting this stoma? And then, of course, you want to think about what can give you the best functional results. Think about having a good skin site, so clean, healthy skin. And does this protrude well? Is this going to be useful for the patient? And then you want to make sure that it's actually visible to the patient. We can get into that later. So important considerations, again, patient education and stoma site selection are in all patients preoperatively if possible. Again, some of these may be in emergent settings, so you may not be able to do that. Think about having the ostomy being well vascularized and mobilized to minimize any tension. Of course, you don't want any retraction, you don't want any ischemia of this ostomy site. And with the exception of parastomal hernia management, most recommendations on management of these stomas are often based on expert opinion. Preoperative education and site selection, again, this is something I cannot stress enough. The education with a preoperative stoma nurse is going to be essential because there are many, many studies that we cite indicating that patients have better adjustments with having stomas, having preoperative education, as well as better outcomes such as decreased complications, decreased site leakage with having site selection beforehand. Things to consider when you're considering a site, consider the patient's lifestyle, their occupation, how their clothing fits or where it's located on their body, such as the belt line, what their living situation is, do they have people helping them out or are they living independently, their bowel function, and whether or not they have disability. I fully recognize that many people do not have a wound and ostomy nurse that can help them with the preoperative siting. So if you are in an emergent setting or if you are doing this yourself, a really important thing to think about is the ostomy triangle. And this is essentially defined as the umbilicus, the pubis, and the as-is. Try to center the ostomy in this ostomy triangle and also within the rectus muscle. So again, it is located, and again, within the rectus muscle. Oops, I'm sorry, were you gonna take a picture? I'll share the slides with you later. So things to consider about, this is from the WOCN Society. When you wanna think about siting a stoma, first you wanna look at the patient's profile when they're in the standing position, where's their abdomen protruding, where's the umbilicus, and of course you don't wanna have the stoma be located below their site of vision. When they're in the sitting position, you want to look for any skin creases such that the ostomy appliance is not sitting within those skin creases and it can be sitting nicely and comfortably. And then of course you want to make sure that it's below the rib line and again within the rectus abdominis muscle. And then of course you want to make sure you mark the patient on both sides after evaluating again for the abdominis muscle, the skin creases, good skin integrity, and then making sure that the site is visible. In a male patient, the same issues apply. Again, do this in the upright position, a supine position, and then making sure that you're not in a skin crease and below the rib cage, and in the rectus muscle. And again, mark this on both sides. The ideal ostomy is visible to the patient. It's within the rectus muscle, and it's centered on a 2-inch area of healthy skin. Again, because of the appliance size, you want to make sure that this is going to be sitting nicely and not cause any leakage. You also want to make sure that this is perpendicular to the abdominal wall. And again, avoid any belt lines or bony prominences or any skin creases or folds. In patients with obesity, we all know that there's higher postoperative complication rates and also higher stoma-related complication rates. So the technical challenge may be due to the patient's body contour or the abdominal wall thickness. So think about doing a preoperative marking above and below the umbilicus. In the emergent setting, think about doing it above the umbilicus. The goal would be to traverse the abdominal wall and create a well-vascularized stoma that sits above the skin. In the emergency setting, think about that ostomy triangle that I just showed you, and then make sure you think about putting the stoma above the umbilicus so that they can visualize it. One helpful thing would be to review the cross-sectional imaging beforehand and think about the relationship to the umbilicus and the anterior superior iliac spine. And then one way to make sure that you have this vascularized ostomy that sits above the skin is to make sure you do have extensive mobilization. And there are tricks to making sure that this occurs, because again, putting up an end colostomy with a fairly short and thickened mesentery through a thickened abdominal wall can be quite challenging. So a couple tips to doing this is that you can traverse the abdominal wall on a thicker abdominal wall using an Alexis wound protector. You can separate the fascia from the fat and then try to pass the ostomy through in 2 steps. This can be only done in open surgery, however. You can do subcutaneous lipectomy. And you can also ellipse the skin and the subcutaneous tissue from this area to allow for the stoma to traverse the abdominal wall and sit nicely. Some adjuncts that were also discussed with some of our previous speakers is that we talk about prevention being a big part of this. How do we prevent having parastomal hernias from happening? Some of this might be using prophylactic mesh placement. ASCRS, or my professional society, American Society of Colon and Rectal Surgeons, provides a strong recommendation to use lightweight polypropylene mesh at the time of permanent ostomy creation. There's also, for permanent colostomies, you can also consider extraperitoneal tunneling. The incidence of parastomal hernia repair after this extraperitoneal tunneling would be maybe about 7% with a median follow-up of 48 months in some series. So in conclusion, the most important things to consider with relocation of a stoma is, again, do you absolutely need to do this? And then if you do need to do this, make sure you educate, prepare, plan, and anticipate any complications, and then using your additional resources such as a wound and ostomy nurse if possible. And that, I'll end it.
Great, thank you.